Ladies and gentlemen, esteemed guests, on behalf of alumni of the School of Economics and Business, University of Ljubljana, it is my privilege to extend a warm welcome to each and every one of you here today. We are thrilled to see so many of you here at this important event. Today, we are here to learn and talk together, hoping to discover new ideas and have meaningful conversations about important questions. Our aim is to explore new insights and engage in meaningful discussions. Without further ado, I would like to extend the floor to Tomaž Turk, the Dean at the School of Economics and Business, University of Ljubljana.
Thank you very much. Dear esteemed colleagues and guests, dear alumni members, dear students, welcome to our School of Economics and Business. I'm very happy to address you before we start with today's event. I would like to say that today's event is a part of a large mosaic of discussions that we have at the present moment about our health system. And our health system needs a bit of reshaping, as we all probably know and are aware. You might ask yourself, what has School of Economics and Business to do with health? Because we are not Faculty of Medicine or something like that. However, a lot of things are connected with our health system, like macroeconomical conditions that we are facing in Slovenia and European Union. There is a challenge of aging population. There is a challenge of efficiency of business processes that are being run in health organizations and other organizations which are supporting the health system. And of course, the actual challenge of digitalization. All these things are taught at our school. So not just taught, but also very intensively researched. And we hope that we will put together today also with today's event one small piece of the puzzle, but not just put one piece of the puzzle, but also to look around other pieces and to set up the whole picture for our society. Thank you very much for your attendance, and thank you very much to all guests that you responded to our invitation. Thank you.
Thank you, Tomaž. Unfortunately, our Minister of Health was not able to attend the event, but she really wanted to welcome everyone online. So we have a recording, but it is held in Slovene. So we will provide a translation.
Spoštovani, veseli me, da vas lahko nagovorim ob začetku dogodka, ki naslavlja priložnosti in izzive zagotavljanja na vrednosti temelječe zdravstvene obravnave s poudarkom na ustreznih digitalnih rešitvah in informacijski podpori. V Sloveniji smo že leta 2022 pripravili usmeritve za uvedbo na vrednosti temelječe zdravstvene obravnave ali na kratko NAVTES. Zaveza za uvajanje NAVTES je ena osrednjih zavez mojega mandata, ki bo prispevala k uresničitvi enega ključnih ciljev, to je izboljšanja kakovosti v zdravstvu. Zaveza za uvajanje NAVTES namreč pomeni zavezo za vzpostavitev ustrezno podprtega merjenja zdravstvenih izidov za paciente z določeno skupino diagnoz v določenih časovnih točkah, na primer pred posegom in po njem ali v smiselnih daljših časovnih razmikih pri kroničnih boleznih. Na osnovi meritev spremljamo spremembe v zdravju pacientov in določamo vrednost, ki jo zdravstvena obravnava prinese pacientu. Merjenje izidov zdravstvene obravnave je tako osnovna izhodiščna točka, na kateri se gradijo analize, primerjave in sprejemajo odločitve o nadaljnji zdravstveni obravnavi. Zaradi sprejemanja odločitev na osnovi kakovostnih podatkov o izidih, pa tudi stroških zdravstvene obravnave, lahko NAVTES izboljša učinkovitost obravnave, zviša njeno kakovost in posledično vodi do prihrankov ter večje uspešnosti celotnega zdravstvenega sistema. Ob pripravi in v procesu osveščanja deležnikov o usmeritvah za uvedbo NAVTES se je izkazalo, da ključni deležniki v našem zdravstvenem sistemu največjo prednost koncepta NAVTES vidijo v tem, da novi pristop v središče obravnave postavlja pacienta. Prednosti pa so tudi v nadgradnji plačevanja izvajalcev v skladu z doseženimi izidi, integrirani obravnavi, preglednosti izidov zdravstvene obravnave za pacienta ter v sodelovanju izvajalcev in izmenjavi dobrih praks. Današnji dogodek pozdravljam prav zato, ker je namenjen predstavitvi dobrih praks bolnišnice Karolinska, ki ima bogate izkušnje pri razvoju in implementaciji NAVTES. Vsi uvidi bodo zagotovo koristni za naš zdravstveni sistem, v katerem trenutno načrtujemo pilotne projekte uvajanja NAVTES, in sicer na področju kardiologije, ortopedije, oftalmologije in onkologije. Želim vam uspešno in plodno razpravo ter se veselim zaključkov okrogle mize.
I think this was a great starting point for today's discussion. But first, let me invite our esteemed guest, Patrick Hemming, the head of medical information at the world-renowned Karolinska Hospital in Sweden.
Hello. Thanks for inviting me. I'm super excited to be here. I really love Slovenia. I've been here just one time before. I think it's super beautiful and you should be proud of your country. So thanks for inviting me. So I'm going to talk a little bit about our experience at Karolinska University Hospital. So the theme here is that, well, we try to create value for our patients, right? That's why we coming to work. If you work in healthcare, that's the only reason why you go to work every day. So I only care about doing good things for our patients. Everything else is secondary. It's just a means to an end. It's all about the patients. But I'm going to try to convince you that to accomplish that goal, we have to focus on data. And I think it's going to be obvious what I mean by that in a few minutes. So just to place me in the world, there's Stockholm in Sweden. And I don't know too much about Slovenian healthcare, but I think it's not too dissimilar. Most of it is tax financed and free for citizens. But we have different healthcare regions that have the sort of task to provide healthcare for the people living in that region. And Karolinska University Hospital is the university hospital in Region Stockholm. And in Region Stockholm, we are about 2.2 million people, about Slovenia. So Region Stockholm we have the same challenges, the same size that you have here in Slovenia. So maybe it's relevant what I have to say. I hope so anyway. And this is really, I could stop, if you understood this slide, I could stop here, because to make it super simple, what are we doing all day long when you go to work in healthcare? We're making decisions. That's all we do all day long, making decisions. And what do we base the decisions on? We base it on data. And if we have bad data, we may make bad decisions. If we have good data, we can at least have the possibility to make good decisions. So this is it. If you understand this, what it means and the consequences, I could just stop talking, but maybe I should just spend a few more minutes explaining what I mean by this. This is, my colors have been strange here, but okay, that's fine. This is healthcare in one slide. If you understand this, I would say you understand a lot about healthcare. That's why it's a little bit messy, this image. So you can start, every healthcare, you have two phases. You have an investigation phase and a treatment phase. This is true for all the patients. symptom, the patient has some kind of health problem. That's why they contact healthcare. They need some kind of help for some problem they have. Then we need to do some kind of investigation. And we want to find what is the diagnosis. If we have the diagnosis, we can plan for the correct treatment and we can treat the patient and follow it up and hopefully we see that we did a really good job. If we didn't do a good job, we have to redo it and do better. And in the image here, I just want to show that the patient there to the right, the first thing that happens is that the patient seeks help from healthcare, either by walking through the door or by contacting us for some mobile app. In Sweden, we have a mobile app that can be used for every citizen to contact healthcare and chat and have video visits and so on. So it can be digital or physical. So the first thing healthcare does is try to understand, so, okay, what's your problem? So we collect a lot of information. For example, where does it hurt? Or whatever it may be. And then we collect that information and we document what we found. And then in almost every case, we have to collect a lot more information before we know what to do. We have to do all of lab testing. We do have to do X-rays and imaging and all stuff like that. Hopefully, when we have collected enough information, we actually know what to do. And then we got to step 2 there. We use the information to make, hopefully, great decisions. And so we combine information about the patient with medical evidence to say, in this situation, you should do like this. So the first problem is that I really, if anyone is interested in healthcare, and I assume you're interested, that's why you're here, please make a visit to a local hospital or a GP office. Try to get the opportunity to do that. It's a mess. It's fax machines, telephone calls, post-it notes, whiteboards, people running around trying to find the right information. Total inefficiency. We spend so much wasted time trying to find the correct information. We could actually save your healthcare budget if you could squeeze out what the inefficiencies. I can guarantee it. We have done some calculations. So if you're interested after, we'd waste so much money. Anyway, and if we finally make the decision, unfortunately, it gets even worse because then we have to coordinate a whole team of people to take care of the patient. You have nurses, you have different kinds of physicians, you have home care, whatever it may be. And all of them have to find effective ways to work together to help the patient. And it really doesn't work with phones and post-it notes and faxes. Information gets lost. It's a really big mess. And at the end, this might interest you economics types in here. We don't really know what we're doing on a whole scale because we don't measure it systematically. We hope we're doing good. So at least it's like almost like a prayer. Let's hope we're doing the best thing we could do, but we really don't know on a systematic level. We should know. So then what is good quality healthcare? And this is not my idea. It's very standard. It's from To Err is Human. Something I can recommend you reading. It's from over 20 years ago, but still true. We want it to be safe, effective, patient-centered, timely, efficient, and equitable. And equitable, I think it's super important in Sweden, I guess here too, because you have a social care system. You don't want to unjustly favor certain groups of patients. Everyone should have the right standard of care. So, and this is not so easy to accomplish actually. But so how do we measure it? I have grayed out the left side, but not, because I'm not going to talk too much about that today, but because I have to save some time. But the 3 aspects, you have to see, is the structure right? What means have the right facilities? Do we have the right equipment? Do we have the right human resources? Do we have the right organizational structure? Super important, but I don't have the time to talk too much about that today. Then you have the next step is the process step. You have to focus on, okay, so what's the actually, as you said, business process? I would call it the care process, but it's the same thing. Because if you don't know what you're supposed to be doing, how can you know what's good? What is good? You have to know, set the standard for what is good. Otherwise, you don't know what to measure. And there's things like, what's the correct way to arrive at the diagnosis for this particular patient? What's the correct treatment? And we have to define it in what we call clinical pathways. It's really a standard. We say, if you're a patient with a breast cancer, this is the step you should go through. This is the way you investigate the woman. This is the way you treat the patient. This is the way you follow up. So you have to define the standard of care. So otherwise, you don't have anything to measure, because you don't know what is right, what is wrong, what is correct, what is not correct. So you have to have the process in place. And then you have the foundation to actually, okay, what is a good outcome? What is good when it comes to results? And I'm going to talk a little bit more in the later slide, but it's basically things like morbidity, and that for you, that is a new term, is how ill are you, basically. It's a kind of illness measurement. Are you very ill or but just a little bit ill? And that's morbidity. And mortality, well, are you alive or not? That's kind of digital. And cost, that's self-explanatory. Quality of life is something that you have to ask the patient. So what's your quality of life? How do you feel? Can you live the way you want to live? Can you do the things you want to do? And patient satisfaction is oh so underestimated. I think traditional healthcare, we have been super arrogant. We have to be a lot more humble than we have ever been to actually dare to ask a patient, how did we treat you? Did we respect you? Did you understand your needs? Everyone is not the same. So that's super important, and I'm super passionate about that. And so how do we actually improve quality of care then? The problem is that we have organized ourselves in silos, like in a functional silos. So we have primary care with GPs, you have the oncology department, the cancer doctors, and then you have to collect people in this flow with the surgeons, pathologists, and they have to come together and talk about what should we do. And then the patient can be operated by the surgeons, then have to go to the intensive care units. And for you economists in here, what you get is you have a local optimization with least a global sub-optimization. Because when all these units try to optimize the use of resources, now you get something called in economy the Forrester effect, whiplash effect. We can talk about more later, that it gets very suboptimal if you have the horizontal view of the patient, if all these units try to do the best they can. And we can talk a lot about that. We don't have time for that now, but I just want to emphasize you should really take the patient's perspective, see the flow from the patient's point of view. And you have to ask yourself, when the patient comes out to the right there, so you have to look for the functional thing. Functional are things like, can you move around freely? Can you walk? Can you carry your daily life? Can you go out with your friends? What can you do? Functionally things. Can you live your life? And then you have satisfaction, things like you ask the patient, how did we treat you? And then you have the clinical side. It's more like medical, typical stuff, like we can see on an X-ray that the tumor is shrinking over time, stuff like that. And they have the cost. And so what do? We have to standardize the care process by using sort of evidence-based clinical pathways. And for you guys who don't come from research background, evidence-based mean basically that you say you collect all the scientific studies that has been done. You try to say, okay, can we find a common agreement on what is good for this particular case patient? And you write it down. First, you start by collecting all the clinical experts. They come to a case, say, can we please agree on what would be the correct way to treat this patient? And then write it down. And then you say, okay, you say, which patients should be included? Okay, all women with breast cancer. I'll say, then you have guidance on all these steps for this team. Okay, this is the best way to treat the patient. And this is the way we should all do, regardless in what hospital we work or in which part of the country we work. And this is just to be more concrete. You have to help me check for the time. What time is it? How long have I been speaking? Oh, then good. I don't have to speed up. I can slow down. So this is the 6 regions, but now I just want the real cancer centers. I just give one specific example. I've organized this for cancer patients in Sweden. So they had agreed here in the middle. It's publicly available, and if you knew Swedish, you could just Google it, and because it's public and open. You can see the nationally agreed upon all evidence-based guidelines. You can click on them and see, okay, so what kind of lab test should I do? What kind of imaging should I do? What kind of medication should I give? So you just choose one clinical pathway and you know what to do. And we have defined, in cancer, we have about 30 of these evidence-based guidelines. And within those, we have defined what you economists would call KPIs, key performance indicators, that defines what is good for one particular pathway. And those things are automatically reported to our national quality registers. They're called INCA. That's a company that's have the mission to do that. So all oncology clinics in Sweden reports in a standardized way, and we can compare. So we compete. Everyone wants to be the best, of course. And right now, of course, Karolinska is best, obviously. Otherwise, I wouldn't have mentioned it. But so that's just one example who have implemented this on a national level. But okay, how do we know what is best practice? We said a little bit about that. What is good? It's actually surprisingly hard to define what is good. So that's worth thinking about. But then perhaps even more important, I think, it seems that, okay, sometimes you think it's so tiresome to come up with the KPIs. You think, now we're finished. Okay, finally we have the KPIs. But then we have already only barely started, because how do you implement it for real in healthcare? How can we make sure we actually work in that way for real, not just talking about it? And then the next thing is, okay, how can we make sure that everyone know how we're doing? Not only some managers sitting in some ivory tower somewhere, but everyone in the care, from the care team, from every nurse, every clinician, the patient's relatives. How can we make it totally transparent for everyone how we are doing? And then how can we improve? Because, sorry to say, at least we at Karolinska, we are far from perfect. Maybe you are, but we're not. So we have to constantly improve ourselves. And so what we really want to do, what we talk about, is to create a learning healthcare system. And that's something that actually was, the concept came out in the US, I think it was 2007, from the Institute of Medicine. They started talking about the learning healthcare, that you have to support the best practice, but then you have to feed back and learn and improve constantly in a loop that never stops. So for us, first to stop the practice, make sure we use the best evidence. Next step, we have to collect the data and learn. And we do that in two ways. Every person who works at Karolinska have two jobs. Doesn't matter who you are, you have two jobs. One job is to take over the care of the patient in front of you in the best possible way. The second job is to make sure that the next patient you see gets even better care. Always. And it doesn't matter if you're secretary, if you're whatever you are. You're all responsible to improve the service we can give to our patients every single day. That's the only reason why we exist. If we don't do that, we could just go home and start doing something else. And then the second part is clinical research. And clinical research is as important as healthcare at Karolinska. It's given equal amount of money, equal amount of attention, and equal everything. Because you have sometimes the clinical improvement is something you do in your daily work. I mean, you can say, for example, in a nurse say, can we register this patient that comes into our ward in a more effective way? On that's a very basic level. It could be, can we move the medical cabinet someplace else? You don't have to walk in the corridor so long. That's the sort of very, very granular. And that has to be ingrained in the DNA of every single person who works at Karolinska. But then we also have to do clinical research. That's the big moves. Like to say, let's say, for example, we have a drug company come up with a fantastic drug that costs, let's say, 100,000 euros a year. That's quite expensive. And no one has unlimited amount of funds. So what we try to do then is, okay, let's see. We know that there's something called in the number needed to treat. I don't know if you heard that, NNT. It means you can actually study to get the benefit. How many patients do you need to treat? Because if you didn't know that, there's no drug that benefits every patient. Such a drug doesn't exist. And especially in psychiatry, for example, it's very bad numbers. I mean, sometimes for some of these normal psychiatry, you have to treat about 200 patients to benefit one. And not many people know this. So what we're trying to do is to really target the treatment to particular patients. And that takes clinical research, because we have to study among this group of women with breast cancer, somewhere in here, there's a subset of patients that will benefit from this expensive drug, but we can't afford to give it to all of them. So we have to find the subset of patients that can actually benefit, and then we can afford it. So that's why clinical research is also super important. So what I want to go into now, unfortunately, we don't have the best possible information flow. And this is just to illustrate that, okay, so primary care sends the fax to oncology, but then have to have a team meeting that we talk to each other to get the information. And then the team has to call down to the surgery and, and then send a letter. This is just made up, but you get the point. So what means is that on to the right, there's a big question mark, because we don't have any data, because the data is in normal snail mails, and it was lost in a phone call. Someone said something to someone, was a fax printout laying around somewhere. What can you do with that? Nothing. So this is so you have data, what I call data silos. So you have to really do something about that. And this is what we really want to do. I'm talking about the feedback loop. So when you have the feed forward, we make sure that everyone knows what have the back mirror. What happened before I saw the patient, and I have to know what's going to happen when the patient leave me. So you have the information must flow over there, and then you can measure the outcome, and you can use the data to improve, and then you do the feedback, because when you do analysis and improvement, you have to feed back both to every single unit, but also for the whole pathway. What can we do better? And this, it's impossible to do with manual effort. You can't have employees running around collecting the information, writing it down in an Excel spreadsheet somewhere. Totally ridiculous. This has to be automated, the whole information flow. And these are just to give you an idea. That's kind of a lot of data you have to collect. So these are the example from the clinical, functional, satisfaction, and cost areas. That's quality data. So clinical, I talked a little about that. Functional is things like mobility, cognitive function, self-care abilities, pain assessment, and so on. I just got to give you an impression that it's not like easy. It's actually quite hard to get hold of this data. So where does it come from? I can tell you, you can't get it from the fax prints out and the medication list on paper or whatever. That's a mission impossible. So many people have to collaborate to do it. And this was just my brain dump, so don't read it too carefully. But it's like the data on the left, patient has to be able to report what the prems and prompts, that has to come to the patient. Clinicians have to do something, administrative stuff, pharmacists, a lot of people involved to make sure that we have the data to support quality improvement. And you have two ways of setting this up. I tried to come up with an easy analogy for you guys who are not super nerdy IT people. We're strange people. We actually like IT. So here you have the view. This is sort of the email. Who among you have tried to do a project together in a group sometime? Everyone, I guess. Yes. So how do you collaborate if you're not physically together? How do you set it up? Do you use email? Sorry? So how easy is it to write a project report using email, mailing an attachment back and forth? Not trivial, right? Because did I get the last version, or did she change that now? Well, maybe I have to call her. Did you change that now? Or you can, if you like more than 3 people, get messy quite quickly. The better way is to do what you do to right. You actually do it thing like using Microsoft Teams. You say you create a Teams space, just put up the document there. And then we always update the same document. That's a much better way to collaborate. Did this analogy work? Do you get my point? Not email, Teams. That's the IT strategy. And this is somewhat more technical. I apologize for that. But in most hospitals, you have a lot of data silos. And that's if you have the information in the IT system at all. It gets even worse when you have papers lying around everywhere. But even if you have digitalized, you can have one IT system for the labs, one system for the intensive care, and so on and so forth. The problem for the people on top there is that they spend tons of money trying to talk to each other. What did you do? Okay, I didn't get it. What medication did the patient take? Oh, what doses was it? How long was it supposed to take it? Or what was the fluid balance? What lab test did you do? You spend tons of money on top of it just to try to move the information forward. And for the IT people, it's a nightmare, because how can you update this and create new functions? Because you have to do it in many places, and the systems are not built to be changed, so it's super messy. And then you can't get the data out to analyze it, because it's locked into all these different kinds of systems. So we're moving over to the right. We'll never get totally to the right, because we always have some of these things left. We can talk about that if you have some IT nerds in the room, but otherwise just forget about it and say what we need to have all the relevant data collected in the standardized ways, accessible in one place, one source of truth. I know if I look in there, I know exactly what medications the patients were on. I will know exactly what allergies the patient are having. I know exactly what has happened, what's going to happen. Otherwise, you can't have many sources of truth, and it becomes messy very quickly. So this is just something we do to be more specific. This is a patient up there, so using our mobile app. And they can use it to book video meetings, and they can do appointment booking, and they can chat with their care provider. But in this context, just want to measure the clinicians up to the right there, they can together, they can actually, without using IT people, decide what kind of questions do we ask the patient that they can tell us how they're feeling and what they thought about our care. And then we can just push that form out to the mobile app. The patient fills it in, and it goes into our platform. And then the quality assessment can there's one place to find all the information, but it's collected. It's organized, like a very nicely organized library. You know where to find every book. It makes it a lot easier. And this is just what we do for reporting. This is an example from the cancer register. So we have information from all these different people who may use different systems. We collect it in one place and then send it off automatically. And then we do this together with the example I mentioned before, the quality register people who are actually on the west coast of Sweden, so as far as we can come from Stockholm, they have the same kind of platform. So we collect information, organize it in a systematic way, so we can build our patient overviews, to create decision support, and do our own internal quality reporting. But then it's super easy, just push it over to their side. And then they can say, okay, we can package it. So this is the information needed for breast cancer patients, prostate cancer, and so on and so forth. Much more efficient. And you can feed back the data in real time. You don't have to have people running around for several months collecting the data and then sort of try to make sense of it. This is more or less automatic. This is my last slide. This is really, I like this picture, because I would prefer you look to the top left and forget about the right side. This is what it's about. Not the right side is really totally unimportant if you don't forget the left side. So everything to the right is in service of the patient. And what we're doing here, so we're building this because I'm just to show you that, yes, we're super interested in value-based health and quality reporting, but there's so much more we need to do with the data. We have to support better decision support for our clinicians. We have to work with something called precision medicine. It's really to tailor the treatment to each unique individual. And then we have we have some initiative called Hospital at Home, where actually we can provide care. So the physicians are in the hospital, the patient stays at home, but we can monitor, the heart rhythm and the breathing frequency and so on. So the data just collected automatically. And then we need to do research, and we know so there's a lot of demands for data. So it's a huge task to really make this work. And I just want to finish with one thing that, because this is dear to my heart, that IT is too important to be left to IT people. It is. And also, the last thing I can say is that if you don't know, if you work in a healthcare organization and you go home after the day and you don't know what kind of good you have done for the patient, you shouldn't be there. You should, every day, you should know exactly what you did to benefit your patients. That's the only right to be there. And if you do that, you realize you have to have the data, because otherwise you don't know. You have no clue what you're doing. Yeah, I'll stop there. I think I kept the time almost. Thank you.
Thank you so much, Patrick. It's impressive, really. Now I would like to invite all other guests also to join me here at the stage. Professor at the School of Economics and Business, Ljubljana University, Petra Došenović-Bonča. Anže Drolc, Director of Business Development at Better. Nina Remškar, member of the Cabinet of the Minister of Health. And of course, the moderator of the roundtable, Miro Gradišar, professor at the School of Economics and Business, Ljubljana University. Thank you.
Well, I hope we 1, 2, 3. Okay. Well, I browsed the website last time, and I found web pages top 100 jobs. And at the top of that list, which was created not just by using financial criteria, but also other criteria, I found the most jobs from healthcare and informatics. So you said before that there are some strange people who like informatics. We are strange, but we love our job and we are happy. So I think that the public here is from healthcare and from informatics, and we should be happy because of that. But well, if I would ask you, are you satisfied with present state of our healthcare system? I'm sure that the most of the answers would be negative. So I think that we should do something. And it seems that actually the only direction which is the most promising, it is value-based healthcare. I can't imagine anything else, actually. And this name was coined 18 years ago. Well, 18 years is a long period of time. And we could expect that period, there will be a lot of countries which successful implementation of value-based healthcare. But unfortunately, I think that there isn't the one which would completely succeed in implementation of organizational model of the health. So it must be very difficult to think. So the road is bumpy, it is full of roadblocks, and most probably never end. But follow this road, and I've read that there are 3 necessary conditions which must be fulfilled for successful implementation of value-based healthcare. First, Ministry of Health or government must support these activities. Then second, appropriate information system. And third, knowledge to know how to analyze data which information system is gathering. So I think we have here in the round table the members which are familiar with all those 3 necessary conditions. Well, so I would like to answer first question for Nina, which was is in 2022 an expert panel headed by Health Minister Valentina prepared guidelines for implementing. And the question is, can you briefly outline the main recommendations of the guidance?
Yes, of course. So thank you first for the invitation to join this panel discussion. It's great to be here, and it was a very nice presentation. So I'm still impressed by that. And now to the recommendations that were published in guidelines. So the first recommendation is definitely to carefully select the medical conditions where we want to implement measurement of outcomes that matter to patients. And there are some criteria that are also described in these guidelines how to select. So some of the criteria are that we need to have a large patient population, which is good if it is homogeneous, yes. And if the outcomes can be measured in a short period of time, maybe within a year already, that we get some results. And there are, of course, other criteria, but on the basis of that criteria, we decided at the Ministry of Health to start, as the minister said before, in 4 areas, which are oncology, orthopedics, ophthalmology, and cardiology. Then the next recommendation is definitely to have very supportive, strong, and motivated teams on the local level in the hospitals and also on the national level. And this is related to the next recommendation, which is to simultaneously implement value-based healthcare in all the institutions where we meet the patients with certain diagnosis. Then the next recommendation is also related to that, as we saw before, we need a single digital health platform which supports collection of data in all locations, in all institutions where the patients are coming in. And then, of course, we have also to implement analytical tools to change the data to the information that will help to help us to decide, to help us with decision making. And maybe last recommendation that I would mention here is implementation of incentives for service providers. And here, I'm really looking forward to hear some of the suggestions maybe from Karolinska, because I believe that they have some good practices. So yeah, these are the main recommendations, I would say.
It's difficult to measure quality and value for patients. How difficult is to measure? By your opinion, what would be?
To measure health outcomes, yeah. So yeah, definitely, as we know, as we have seen, this is a very complex process. And it's not just medical treatment that influences health outcomes. There are other factors that influence them. So it's lifestyle, it's socioeconomic status, and environmental changes, and many others. And it's also complex to bring clinical data together with the data that we are bringing from the patients, PROMs, patient-reported outcomes. And we have to bring them together and analyze them, which is definitely very, very difficult. Luckily, there are some international institutions also suggesting some standard sets of data that we have to collect, and it is also recommended in the guidelines, and I didn't mention that before, to take this questionnaire and the data mix that is already ready, to translate it and to validate it into local language. And this can help us then to measure what is the outcomes that are important for patients. I don't think that there is, I don't have any really good recommendation, but most probably here are other people that know much better than me.
Top question. Is this measurement subjective or objective?
Which measurements? The patient reported?
Well, outcomes.
Both, yeah.
Both, yeah.
Yeah. Yeah.
This is the only way, I think.
Mm.
But how then to combine both results? This can be a problem.
We need people like Patrick here, and we definitely lack this kind of people in Slovenia that are medical doctors and IT people in one person. So
okay, now I have a very long question. Well, there has been a lot of attention on measuring health outcomes that matters to patients. But as Porter and Lee note, quotation, the absence of accurate cost information in healthcare is nothing short of astounding. And end of quotation. So we need both health outcomes and costs per patient to be able to determine the value of care. And okay, but how well, the question is actually short, so it is, how well is the Slovenian healthcare system performing in terms of costing healthcare services and providers?
You're looking at me and it's the cost, so I'm assuming it's my job.
Yeah, sorry.
So in terms of, yes, what Nina already said, when it comes to outcomes, we have a completely different challenge than with costs. With outcomes, we have too many indicators and we have a problem of choosing out of many indicators the select few that are most appropriate. So there's been a lot of focus on outcomes, a lot less focus on costs, however. I think that is a common situation across all countries that are struggling with implementing value-based healthcare. It's a challenge for Slovenia, definitely. We are far from really collecting costs per patients. We are still currently in a phase where we have department-centered cost accounting. So we look at costs in silos according to specialties. We don't use patient system costing approaches. We also, very much so in Slovenia, we don't focus on costs, we focus on charges. So we actually look at how much is the Health Insurance Institute paying, and we're focused on that, not the actual costs of actually delivering care. So a lot of these problems are very prominent in many countries. Slovenia is no exception. Now, there are many real problems that result because of that. We have a lot of cost shifting between providers because of that. A lot of the times we are creating incentives for providers to kind of focus on those services that are valued better by the payer, not the services that are really most necessary for the patient. So a lot of these changes are, a lot of these problems are prominent. Is it something that we can easily solve? It's actually not a question of knowing how to do it. There's a very standard methodology for estimating costs per patient. It's called time-driven activity-based costing, something that, you know, if you study accounting, you've probably come across. So it's not knowing how to do it. That's not the problem. The problem is that we have very fragmented processes. You talked about processes, but we still function in silos. Even when I look at, you know, any report in Slovenia, when I open the report of the Health Insurance Institute, the data is for primary care, for secondary care, for tertiary care. I'm not interested in that as a patient. I want to know how much does it cost in Slovenia to care for diabetes? How much does cancer burden the Slovenian economy? So we still haven't achieved that shift. So I think that's a big issue. Really putting together the clinical pathways, understanding the processes, because without that, you can't do any costing analyses. Also, we have big variation in processes across different providers. And importantly, we don't create incentives for hospitals to really be mindful of costs. Because many times in Slovenia, payment models, unfortunately, so the prices that are paid by the Health Insurance Institute aren't actually linked to costs. It takes ages for payment models to be upgraded. And I don't know how familiar you are with healthcare, but for example, acute healthcare, which is most expensive if you look at the structure of costs, is funded through what is called the DRG system, so diagnosis-related groups. And we are using an Australian system, which makes sense in one part. We have Australian classifications that we translate to Slovenian. That's all okay because we're a country that's too small to develop our own classifications. The problem is that we still use Australian weights. So our prices are calculated in Slovenia based on the cost ratios from Australia. And Australia is 12 hours time difference from Slovenia. So very probably not relevant to what we have. So I think all of these issues are an issue, are a problem, but they can be easily overcome. It just takes someone with a strong conviction to actually change the things that are currently not working.
Well, you mentioned processes which contains activities, and each activity means cost. Yeah. And now, with different patients, we have the same disease, different activities, which cost differently. Who will measure that?
That's very much linked to clinical pathways. If you understand the clinical pathways, then it's also very easy because that's the essence of time-driven activity-based costing, because you're focused on the length of activities and the structure of the team that actually participates. So it's easy to calculate the costs for different patients. And you know exactly when you treat a patient, which type of a patient that is, so which clinical pathways, which clinical pathway he went through. So that's not a challenge. The problem is actually understanding those processes, defining those processes, and then just, it's easy then to estimate the number of patients that you treat, and of course, allocate the costs accordingly. The reality in our hospitals most of the time is that we we know the overall labor cost, but we have a difficulty then of actually allocating the time of physicians in these different activities that they undergo.
The bearer of costs should be patient.
I didn't understand.
The bearer, the one to which costs are allocated.
It has to be linked to the process and what happens to the patient, definitely.
Okay. Okay, now I have a very short question for Patrick, which is, in your experience, how can healthcare providers could be incentivized to implement VBHC?
Short question.
But long
let's see if I can give you the short answer. I don't know. That's a challenge. Where to start? First of all, I like to start bottom up in my answer. Does it work my way to a strategic level? Bottom up must be the clinician. What's in it for me? That's why I would start. What's in it for me? Why should I care to know about the clinical pathway? Why should I be updated on what I should do? Why should I document what I do in a particular way so we can follow up? So, because, you know, physicians are a strange bunch. I mean, so they're more like cat people than dog people. Do you know the difference? Like, how do you herd a group of cats? It's actually quite hard. So what you do, you have to entice them and sort of make it interesting. So, so what we do is that the data. Let's just one small example. There will be, let's say, for example, take breast cancer. I like to be super specific. One challenge we had was, okay, when do the clinical pathways start? Because we can't start it when the patient has the diagnosis. That's too late, because then we miss the whole diagnostic process. Because we want, for example, one quality measure is how long does it take until you arrive at the diagnosis? That's one important quality measure. So when does it start? And who knows that this patient should go into this pathway? So we decided it has to be the GP, because the GP meets the patient first. So a common situation is that the women come to the GP with a lump in the breast, for example. And then the problem is the GP sees completely unsorted patients. So how should they know that this particular patient should be entered in this particular clinical pathway? They're not so interested in having like some 200-page PDF document that we have like 15 minutes per patient. Oh, now I have to scroll through this screen up and down. They don't do it. So they just don't include the patient in the pathway. So what we did is said, okay, so what's in it for them? Why would they be interested in knowing which patient should go into which pathway? So what we did was we created actually a digital decision support tool. So that's like a battery of questions in the tree that the patient came, and our sneaky idea was, okay, so then we can guide them into but why the clinicians like to do it was that they get benefit. They knew how to help the patient. So we gave them more in direction about which pathway should be entered into. We could help them. We suggest you do this lab test. We suggest you do this kind of investigation. And so they wanted to open this up. They wanted to go in there, and they wanted, because the document was sort of an side phenomenon to the thing that they wanted to get decision support. It happened automatically. So we didn't have to convince them. We gave them something that was of value to them at point of care. That's one thing. So it's not like you can't, well, at least I have never been sexual to have this like dictatorial fashion. You have to do this, otherwise you're fired. It doesn't at least work at Karolinska. Maybe it works here, but you could just, they just throw you out of the room. Yeah.
Can I jump in? I have to. I think one thing that I think we often forget is that we have financial and non-financial incentives. And we just fail to exploit non-financial incentives. Doctors, like professors, we are people that are driven by our internal motivation, most of us. Okay, and whenever we talk about IT systems and data in Slovenia, typically our talks are, what is the data that the ministry needs? What's the data that the Health Insurance Institute needs? I wouldn't start with that question. We first need to provide the data to clinicians. They treat the patient, and then what happens is when the patient leaves their room, they receive practically no information on that patient. So if you want to know whether your patients have died a week after they were discharged, you have to undergo a research project. And in a year or so, you see what happened to the population of patients that you treated. So for me, just give them the information as soon as possible. And in the ideal world, I would, the doctors every morning have a session. They talk about the patients that are in the hospital. Well, I would expect them to talk also about the patients that were discharged a week ago or a month ago. Just give them that information. Without an additional euro, you will have a massive change. There's been research that non-financial incentives are 4 times stronger than financial incentives. That would solve a lot of the issues. Just give them the info. When they compare how they're doing to their peers, we're gonna do things differently. This is what you said.
Yeah, exactly.
You want to compare.
Yes, exactly. And then just to follow up on that. So first, you always have like what's in it for me perspective. How can we make it worth their effort? That's one thing. And another thing you can do, apart from improving their ability to help the patient and see how we're doing. The second thing for Karolinska, where you can't find a physician who's not also a researcher. So what we do is that we actually provide much more effective data to the research projects by doing this automatically. So instead of having you going through application process and wait many weeks and maybe you get the data you need eventually, you say what we do is that we can say, well, for the cases where we've actually implemented the pathways, you actually have the automated data flow to the report, everyone who wants to report, but it also goes into the platform to be used for clinical research. It's like many for the price of one. That's basically it.
I just want to touch on what you both said. It's an interesting topic also from IT, where I come from. It's I liked your statement during the presentation where you said that IT shouldn't be left to IT. I think it starts there. This needs to be a paradigm shift, right? The clinicians, you have to get involved, and we need to start solving the pains on the spot. Because once we start doing that, then like you both said, then people will start using the apps. I had a really good example actually working at a children's hospital. We were testing out some mobile apps and we weren't sure whether they will be using it or not. And we were asking clinicians how convenient that would be. And we figured out that they actually had apps that they bought themselves because they solved some sort of a problem for them. And, they were not standardized. They were not part of the overall portfolio, but they were using them. But then we come also to data that you both talked about. It's not just, how do we get data about cost or reimbursement or quality, because the raw data in healthcare can be then looked through different lenses and through different layers at different points in time. I think that's also quite important. And also when we talk about different care plans, it's really hard to define a care plan, I think, because even if you just broke your arm, but if you have diabetes and if you have another comorbidity, it's a completely different pathway, can be, or at least iteration of. So we need to, I think, have this awareness as well that store core data and then give the ability to different use cases to look at it through different lens, different apps with different algorithms for different point in times. I once got a question from, I think there was some clinicians in the room when we were talking about this open data approach and how you have data all in one place and how you can build an ecosystem of different apps. And they said, oh, this is really good. So then basically nurses can have sort of different apps for the same activities than doctors from different angle. And then someone in the room said, yeah, but not just that. Imagine, nurses, when they start the shift, they are still nurses in the role of nurses, but maybe they work at admission and then they go to a ward round. And then in the evening, they end up in the night shift. So it's not just you have different experience as a role, but even during your life cycle, during the day, you need completely different IT experience, but the data, it's the same. It's just the lens that you look at it, it's completely different. So that's, I think, another aspect that needs to be considered.
If you have time for just one, to be specific, what we did for this cancer pathways was that before we said, okay, now we're going to automatically report the data, so you have to start working a different way. When we sat down, we didn't even ask them this. We said, okay, what can we do to make your life easier when you take care of the patient? What do you need? So, and what they said, what they need sort of what you call it, a back mirror to look in and you look forward. So we provide an app with a timeline where you could say, where is my patient that I have in front of me along this timeline? Is there investigation? Have you had the diagnosis? Are we going in the treatment? Where in the treatment are we follow-up? And we collected the most information on this timeline. We had the lab, and they were super excited about this. But then we said, okay, this was just a mock-up. This was not real because we don't have the data. So if you want this, you have to work like this. And then was, of course, because we want this. So you have to be this specific. So I haven't never actually talked to normal everyday clinicians about the KPIs or outcome measures. That's for the dedicated experts, or really working out the clinical pathways, not the everyday clinicians in the ward. They are just interested in what benefits in it for me, for my research, or for my daily work. Yeah. Actually, but still, systems are smart from other stuff which knows the content. But either way, the result must solve the problem. And there are some examples
involved in some of these projects. Can you tell us more about it?
Yes, so we'll stick to the topic of value-based care. So otherwise this can get really broad, healthcare IT. But yeah, I mean, the value-based care is gaining momentum, definitely, not just in Slovenia and with Karolinska, but we've seen this in other countries globally, because there's clear, I mean, the growing population, especially in the Western world, and the aging of population is bringing certain challenges to the healthcare systems, and it's just straining them out. And that's sort of driving the digitalization and the whole reform of the healthcare systems towards value-based care, because you need to figure out what will help populations stay healthier longer, and if you're already ill, how you can maintain that condition, or if you have a chronic condition, how you can maintain it. So you need to know what's going on with everyone, even when they're not in the system. And most of the time we are out of the system. And obviously, if you want to achieve that, then you need proper IT support, because otherwise it's just impossible. What Patrick was saying, we can start sending emails about how we feel at home, but there's no way someone is going to put a full picture together in a coherent way so that they catch the person that needs to come to the hospital, or, you know, to make sure that the ones that don't need to come to the hospital, they stay at home. And there's examples in UK. You have there was tenders and projects on a national level to implement value-based healthcare. Then in England, there's initiatives like open outcomes, where they're actually building prompts and IT solutions, and they're using similar concepts as what Patrick was saying, open EHR to store the data. Whenever, you know, and if you look at these projects, they always come down to data. So how do we get data from patients, and how do we combine them efficiently with what's already known about the patient from the system, from their history? Then you have examples from Netherlands. There's groups of hospitals who are implementing value-based healthcare. And again, the same challenge, a group of hospitals, because they're working with this patients who also go from one hospital to another. They needed a way to make sure that they know what's going on with patients across all of their group. And they are implementing solutions and standards to do that. Then we have examples of this also in Slovenia. It's been recognized. I know that orthopedic hospital in Valdoltra is implementing some initial sort of projects around value-based healthcare. Then Clinic of Ophthalmology at the University Medical Center is recognized they need this, and now they're trying to implement, and they need to do something also with IT. Then there was some attempts also with the Institute of Oncology. So there's a lot of these examples, and it's quite clear that IT is needed to also help break down the silos that everyone talked about. Because unless we get a more connected healthcare and a more teams-based approach to having a single patient record, virtually at least, not necessarily physically, we can't make this transition efficiently enough.
Can I just add, because even before these projects and these initiatives that are going on currently, even before the pandemic, I think it was 2019 or even before that, 2018, there was a project that the ministry did and was not very elaborate, not IT supported, unfortunately. So it was still pretty much Excel-based data analysis, but still, what they did is they just maintained a fraction of the budget that is allocated to ophthalmology, so to hip replacement surgeries, etc. And they did a special tender where hospitals actually applied to get those funds. And there were some conditions that were linked to getting the money. So they needed to, of course, offer the service and they needed to set the price, but they also had to monitor outcomes. Objective and subjective, so also patient-reported outcomes and quality of life and so on and so forth. So interestingly, what happened is the results actually showed that about a third of patients after hip replacement surgery felt better, a third felt worse, and about a third there was no notable change. So when you have that information, I mean, you have to do something about it because that's a huge waste of resources. And there are some studies that show that about 20% of all expenditures in healthcare are waste in the sense that they don't improve health outcomes. And this one example in Slovenia shows that this is worthwhile doing. Probably not across the entire healthcare system, but for certain illnesses, that the benefit could be huge. This was one pilot. It was one attempt, but I think that this is definitely something that we should continue working on.
Anže, you have presented a few successful projects in abroad, but what is happening in Slovenia? Do we have some examples also in Slovenia? Successful examples.
Yeah, I mean, I mentioned a few, but definitely Slovenia has some interesting or successful examples as well. Across different organizations, and you have, successful projects on a national level. Then you have good examples from individual hospitals or university medical centers. So there's, talking to Patrick when he visited, he was quite impressed with some of the things that we've done, and Slovenia is definitely ahead of several European countries with some of the projects and in terms of the approach to healthcare IT, especially what has been done on a national level with how we have on a national level data stored separately from the application. So we have this teams-based approach already in place since 2013, I think. And the rest of Europe is just now figuring out that actually this is the way that healthcare needs to be done. And we've had it for 10 years. We're not utilizing this data enough. I know there's been initiatives from outside institutions, especially to get access to the data. But also, there's data available. So why don't individual organizations get more engaged? So that's one thing. But it's a solid foundation on which we can now build and do what Patrick was saying, not just on a national level, but also on local level with hospitals, GPs, and we can start connecting them on a data level, not app to app, and not sending emails up and down.
Well, thank you. Okay, some questions for next question for Nina. Well, implementation of VBHC requires collaboration of a lot of stakeholders. And maybe those stakeholders doesn't know their responsibilities. What is the solution for them?
Yeah, there are really different understandings of the roles and expectations from different stakeholders. But even before that, I think even the usage of terms is different among different stakeholders. So we should bring some clarity also there. But regarding the expectation and roles and what we could do there are some initiatives already on the European level. And I noticed a few weeks ago that there is an article published by, I think it's European Alliance for Value in Health. They actually defined the roles for all the stakeholders that are involved. And I think that good suggestion or proposal would be to have a workshop with all stakeholders to first check if they would agree with these roles, if they see themselves like it is described in this paper from this alliance. And another thing is, because something like that we started doing now at the ministry, we have established a working group. The minister mentioned it before in the video. And with this group, it's a multi-stakeholder group where we discuss also the vision for value-based healthcare for Slovenia. And when we understand our roles and we have the common vision, then we can start thinking also about the national strategy and what the action plan should be. And as we have now these 4 areas selected, at the moment we are in a situation of mapping this, also good practices, some of them Anže already mentioned. And we are now trying to see where the gaps are and what needs to be done as a next step. And digitalization is a magic word here, I would say.
Well, payment is still tied to individual services, which is not in concept of VBHC. So what is your recommendation to overcome?
Well, it's not my recommendation specifically. It's a recommendation within the framework of value-based healthcare. It's true what you said. We are still paying for the services delivered. I mentioned earlier, we pay for hip replacement surgery regardless of what happens to a patient still. So DRG payment, capitation payment, fee for service, all the elaborate payment models that we are currently using are still focused on just delivered services, or arrays of services that need to be delivered to patients. So within the value-based framework, bundled payments are suggested. We need to move away from siloed, not just siloed IT systems, but also siloed ways of paying for services. Because now we pay separately. A GP is paid separately, a specialist is paid separately, an acute hospitalization is paid separately. The idea of bundled payments is, of course, that you link payment to the whole value chain, so the whole process that the patient goes through. That, of course, is not an easy task to achieve, because you have to link. The payment actually has to be then shared with different organizations. Why is that a good thing? Because what we want to do at the end is not just to measure outcomes and measure costs. We want to have integrated care. That's the end goal of value-based healthcare. We still have very fragmented healthcare systems. So that integration is not going to happen. So I talked earlier about non-financial incentives. They are very important, but yeah, financial incentives also play a big role. So bundled payments are an answer. However, I think, Nina, you said it initially, there is it makes sense. You would say, of course, we will only pay if you have delivered the value. So if the outcomes were achieved. We need to, of course, recognize that the outcomes are not totally under the control of physicians and the teams that treat the patient. Patients also are responsible for the outcomes. Our behavior is important. Our genetics play a role. So when you design these types of payments, there also have to be stop-loss provisions for providers. So you have to be mindful that you set those payment mechanisms in a right way. But without that, I think it's going to be a very difficult thing to achieve. And in terms of as I said, I think you said that nicely. We now have physicians that operate as islands. And if we give physicians the information, they will change how they behave. But if you really want to achieve better collaboration between them, then financial incentives are going to be needed, and bundle payments are one answer.
Yeah, can I just add to that? I like this word integrated care systems, and there's examples in Europe where this has been sort of actually implemented at the state of law. So England implemented integrated care systems, and what they did is they actually gave budgets now to regions, and they have to use the budget to optimize the healthcare. And that's interesting. And what's interesting is that the size of these regions is between 1.5 million to 2 million patients. That's exactly the size of Slovenia. So we could be a really good pilot country where we could implement that relatively easy because we're small enough to actually do that. And then we get to what you said. Obviously, it's once you start sharing, you have one bag of money, and then you have to optimize on that. Then this should drive the behavior. But obviously, the support has to happen. You can't just say, oh, the money will now have it one bag, figure it out. But the support needs to happen on different levels. And there's first initiatives that are already happening in EU, and I think Slovenia could learn from that and then maybe try to get ahead of that back.
And if I just may add, I think we haven't researched that. It's just my gut feeling, but I think we are wasting a lot of resources simply because we shift costs between providers. And there are duplicative services that we do because, you know, if it doesn't impact your budget, you're not upset about duplicating care and diagnostics. When you bundle providers together, you will change how they approach the processes that they actually execute.
Yes, one more idea to what you just said. When it comes to integrated care systems, it's not then just typical healthcare providers, but you have to include what you said, not just patients, but also other levels, you know, social care, also your education, how you live, how you eat, all of it, because it becomes important on your overall outcomes. You can have the best care in acute hospitals, but then if you go home and you don't have proper diet, or you live somewhere where you don't have heating, you're going to end up back in a hospital quite quickly. So this is also, it changes the perspective of well-being and wellness of individuals. And there was some statistics and research done which says that basically 60% or even more of health determinants are created outside of a typical healthcare settings. So we need to consider that as well. And then we come back to data. If we don't have the data and if we can't aggregate it to find the patterns on which we can then react, it's really difficult to do this kind of changes. We are walking in the dark, or, you know, trying my idea for whatever reason and not yours.
Sorry, but as an economist, I have to point something else out as well. Most of the time when we talk about costs and expenditures, we focus on the healthcare system alone. And we talk about, yes, drugs are expensive, yes, acute care is expensive, but we're ignoring exactly that, these other effects that are created within the economy. We talk a lot in Slovenia about sick leave, so absenteeism costs, and the number that we talk about is 700 million euros, which is only the expenditure borne by the Health Insurance Institute, because they cover the benefits if you have a longer absence. But if you look at the burden for the whole society, it's twice as much. And that's just absenteeism, premature mortality, premature retirement, people not actually working. If you sum that together, you come to a much bigger figure than 5 billion euros, which is the overall budget for healthcare in Slovenia. So I think you need to focus on all of these things, and you need to capture that in the data as well.
And then all of a sudden, we might find enough money for all these reforms and IT and digitalization, right? So we need to look at the value of what we're implementing as well. But sorry, just I have actually a question for Patrick. I mean, we are now talking about Slovenia, but since we have you here, can you maybe share some of your experience, what's happening in Sweden in terms of integrated care and how you're addressing these sort of new trends in healthcare?
Short question. Let's see about the answer. Once again, things are happening on both on the sort of very local level, like in a Karolinska Hospital region, or also on a national level. And on a national level, Well, something that has really accelerated the dialogue is, discussions about European health data space. It's a completely different initiative from the EU, where they emphasize now to regulate by law that we have to be able to share the data, both for taking care of the patient, but also, for secondary use like quality improvement and so on. So that's one context that I really accelerated a national discussion that we have to do this even better. So we do have, for example, for many years, we have had a national patient overview. So we share the most important information in an app, or you can do it in a web browser, whatever, like allergies, medication, and so on. So, and we also, we focus on, okay, what do we have to do in the national level? Because we don't want sort of to create the monster that everything has to be decided by, a dictator on the top. Certain things has to be mandated from the top, but if it can be dealt with on the local level, that's often better. So, I think you call this subsidiarity principle, that you try to push the decisions as far out as you can effectively do, which means that, of course, some decisions has to be made on the national level, and then you should do that. But I think to find that balance is not trivial. And not to say too much, I had a very nice meeting at university hospital before I came here. And there was a nice dynamic in the room between the clinicians worry that the government would do too much on the one hand. And I think it's very interesting because it's not an either or here, it's in both and. So I think, but I just have to take the opportunity to say, I think you're in a great position here. There's 2 million people. You have a very modern infrastructure. You have a high education level. Just do it. I mean, so don't just paralysis by analysis. So because we can talk all day long. Oh, this is so complicated. This is so. Just do it. I mean, small steps. And so I think when I talk to my colleagues, they this is so difficult. This is difficult. This is difficult. But just please shut up. I'm not interested in hearing more about what's difficult. I mean, give me a suggestion. It can be tiny, super tiny. So let's see if I go to, you also have to address it depending on who you're talking to. If I go to a normal care ward, speaking to the really exhausted nurse, complaining about stuff. Okay, so what can you do? What do you have the power over? What in your environment can you actually do? There's always something you can do. Always. It can be tiny things, like, as I said, moving the medication cupboard so you don't have to walk back and forth so much, the way you report. So everyone can do something, and that's the key. So I think if everyone takes responsibility for what they can do and not complain about what they can't do, the world would look much nicer, even in this context. So this was a long answer. So I say that in Sweden right now, there is a discussion on the national level. And it's a little bit back and forth between how much should the government do and how much should the regions and the local hospitals do. But I think the key here is that, well, we're all in this together. So stop complaining, start doing, is my message. Sorry, I just finish this. And so if you don't like... So if you don't like what the government is doing, well, the fuck, do something about it then. I mean, you have a mouth, you can talk, you can speak, you won't be jailed if you have an opinion. Yeah, sorry for my French. No, but I'm actually very serious, because sometimes you get stuck in this, oh, it's so complicated, I can't do anything, or what can I do? And so if everyone from the prime minister to the nurse every day just focus on what can I do today to make my situation, and in this our case the patient's world, better. And I just finish up. So when it comes to the government role now, I don't think it's better in Sweden than it's here. So stop complaining. I mean, nobody loves everything the government's doing or the politicians doing. That's just a fact of life. But I think they do the best they can, most of them. So I think what I try to do is that I really just try to create a dialogue. I mean, and most of them are actually very happy to hear what you're saying. So now, right now, we have this discussion when it comes to how much should we sort of, I mean, now should accelerate the digitalization in Sweden. How do you divide responsibility between the government and the regions and the local hospitals and so on, care providers? And I think, to put it very briefly, I think that what I would wish for, and maybe we can get there, is that I want a government that see themselves as facilitators and creating opportunities to move forward. Because who knows what has to be done? It's at point of care. It is a sharp end of the sword. The people on the floor, they know what they're supposed to do, but they can't do it because they don't have the right environment. They don't have the right conditions. So if I would choose my dream government, is that they have bigger ears than they have mouths. They would go out and listen. And that's what I said to you guys, regardless of your students or whoever you are, if you do something concerning health and you haven't been in a hospital, just run there. And go, I mean, I can assure you they will be welcome. They will put on you these pajamas and you can walk around and just watch like a fly on the wall. And you will get tons of ideas what could be, because you're not biased. You're not sort of, so that's what I'm saying, that now, so there's many things I don't like what the Swedish government is doing, but what I have learned is that you can actually contact, you can talk to them. You can actually enter a dialogue, and sometimes you can even convince them. Of course, not so often, but sometimes. And that may be good enough. So I think the future is bright. And I'm talking about you guys, because you have everything you need. You don't need more money. You don't need more people. You just have to do what you already can do. So if you spend more time doing, less time complaining, I'm not saying that you complain any more than anyone else, but everyone is complaining today, I think. So it is, okay. So I won't take that away from you. You can complain. You do time boxing. You can complain like 5 minutes every hour, but the 55 minutes, you have to be constructive instead. Sorry, that was not, I ranted a little bit. Sorry for that.
Well,
May I add something? Okay, I enjoyed really your statements that you made, but I also wanted to add that now we have a huge political will to do something in this area, and if not now, then I really don't know when. So yeah, it is time to act, and I see our role as a government there. So yeah.
but
Yeah, thank you.
I would like to encourage the audience for questions. Please don't hesitate.
Your system helps collaborate with different doctors from different fields, because as we all know, when a patient comes in, they have specific conditions, they might have different types of procedures. And the pathways are, of course, like I think they have different pathways. So how do you feel that patient, on the other hand, if the results are better?
Yeah, it's also, you ask two smart questions. You make my brain hurt. Okay, so let's see. I think the one way to see it is that if you're going to implement value-based health, I think you alluded to it, you don't start with the most complicated cases first, because let's say broadly, I met your health minister. I don't have to draw here, but not all patients are the same. And in this context, I think I broadly have 4 categories of patients. And so depending on the one axis is it a chronic disease or an episodic disease? That's one thing to matter. And the other aspect is there only one sort of care unit or one provider involved, or is it a whole team? So what I mean, for example, let me give you an example of things we're very good at taking care of in healthcare. Let's say a child gets a severe earache, and you need to contact GP, and maybe they need antibiotics. That's super simple. I mean, they just need one appointment with one GP. They look into the ear and they decide, okay, they need antibiotics. Thumbs up. It's simple. Now, something a little bit more difficult. It's like it's episodic, has a beginning and an end, but several, as you said, several physicians have to be involved. Breast cancer is an excellent example because you can start with the GP, you can have ontologists, surgeons, and so on and so forth. But still, it's so standardized that you can actually standardize the collaboration. So in the clinical pathways for cancer, we have an activity called multidisciplinary conference. That's a standardized activity. So there you have pathologist, surgeon, oncologist, because it always happens at certain points. So that's still doable, reasonably easy. And then move to my other quadrant is we have chronic, but still simple, like the typical example, type 1 diabetes patient. I mean, it's chronic, but most of them are generally well outside of having diabetes type 1. So basically, they do mostly take care of their own health, and just not so often they have a meeting with a healthcare. Just can be one physician they meet, just yearly checkup. That's simple too. But now we come to the really tricky part. That is elderly people with many multiple morbidities. Like they're a little bit hard to walk. They might have heart failure, have diabetes, and then their eyesight is a little bit bad. That's super complicated. And then actually at this point, we don't have the same kind of clinical pathway for them because we have to shift the mindset because it's not end. It's not like now we're done. So we have to say more. Then the shift, actually, we talked about subjective and objective. So in this case, actually the shift is slightly more to the subjective side. We try to optimize the quality of life, which might mean we don't always go for the most aggressive treatment. We can say it's more important that you can go up and move around in your apartment, you can take care of yourself. That trumps. You might have a slight chance of improving your heart failure if you're really aggressive with the medication, but maybe you have side effects, so the quality of life go down. So it shifts what's important. So I think that's one way. If you have this grid with episodic versus chronic, and either single or many, you could start sorting out what is good, depending on what context you are. Because if you don't have any sorting mechanism, you will be lost. Because, of course, on one level, every patient is unique, but you can't create a pathway for every patient. I mean, that's not possible. So you have to find some way to create these different buckets, types of patients. And just to finish this up, for the complicated patients, what we're doing is basically, I don't know if you know, have you heard economists have the customer relationship management? You heard about that? That's so, yeah. So actually, it's very applicable here. So what we try to conceptualize around these patients is that if you view them as customers and you treat them like a customer, what we do is, okay, we have to have one customer responsible person from healthcare. Normally it's a nurse who's sort of overall responsible. And then she can invite other people. It could be a GP, it can be a cardiologist, whoever needs to be involved. And they can be physically dispersed. They don't have to be in the same place, but you say, okay, to take care of this patient, we need all these competencies and these professions. So actually we have a case management system. So, and in the case management system, we collect all the data in one place. So then the whole process gives you the wrong idea, because it gives you an idea that's the beginning in a linear process that goes from left to right. But in the case it can go round, it can go back and forth and up and down on other direction. But you can still say on a time-based level, you can say twice a year or 4 times a year, you do an evaluation. What's the quality of life? What have you achieved? And then you can still measure the quality of healthcare. But it's different. So I think the first step is to get out of the mindset that a clinical process is always like a linear thing going from left to right. But actually, in real life, that's a minority of the cases. Yeah. 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 Mm. Yeah. 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 Mm. Yeah. Yeah. Mm. Yeah. Yeah, exactly like that. Mm. Yeah, I just have to remind everyone who's not working in healthcare, this is something that has to be done regardless, because somehow you have to take care of the patient. So, I mean, it's not like option. Okay, this sounds really hard, so maybe we shouldn't do available healthcare. But well, you still have to do it because somehow you still have to coordinate. Everything has to be done for the patient. Why not just do it explicitly and make it as efficient as possible? And just to finish off, to say, if you want to learn something about efficiencies in healthcare, you really shouldn't talk about the physicians. You should talk to the nurses. That's a tip from a coach, because physicians are so spoiled because someone else makes sure they have the information they need when they need it. So this is obvious for anyone who's working in healthcare. So if Anja has said that if you want someone to champion the focus on data and data flow, you should really talk to the nurses and not the doctors. Because and I can just say, in Sweden, we have a huge problem with a working environment for nurses. It's easy to recruit physicians to Karolinska, super easy. Everyone wants to work there. But the nurses is kind of tough because we have a lack of nurses who can really be picky where they want to work. And one thing they say is that for them, super important, how much of my time can I spend actually taking care of the patient, and how much do I have to spend in front of the computer or sorting papers? And they spend far too much time doing administration. So it's not only a question of providing, it's actually keeping nurses in healthcare, keeping them motivated and enjoying go to work. So that's many dimensions. Yeah. Sorry for ranting again.
Well, thank you. The time, unfortunately, is running out. So for the conclusion, just a question for you all. Can you, in just 2 sentences, sum up your final thoughts in the form of giveaway?
Thank you. Yeah,
Takeaway, sorry.
I would I agree that Slovenia is actually in a much better position than many other countries. And I had a talk this week with the ICHOM organization, and they also confirmed that not many countries are that advanced as Slovenia is. And as I said before, we also have a political will, and we have to work together and to accept our roles and to do the best we can, because we are doing that for the patients.
Thank you. Thank you.
Super briefly. The patients deserve better, and you can do it.
I said 2 sentences.
I'm also going to use a quote. I hope I can remember it. So the problem isn't doing the right thing. The problem is knowing what's right. In our case, we know what's right, and we know all the methodologies. We are equipped to do it differently. So like you said, we just have to do it.
Yeah, I would just join this thought. Let's do it. We know what to do. Let's trust ourselves, and we need to focus on data to make the next steps necessary. But let's do it.
Well, let me express my gratitude for all the participants of this roundtable, sharing with us their thoughts, their information, their knowledge. and their time. So thank you once again. And now I would like to invite you in the lobby of this hall where you snacks and drinks. Thank you very much.